Hello, everyone. Today, we're going to be presenting on our EANM accepted abstract titled A Fully Automated Method for Bladder Segmentation in PSMA PET CT Scans. Our project's focus is on improving the clinical workflow for prostate cancer diagnostics. A commonly used imaging technique for diagnosing this cancer is PSMA PET CT. This type of scan results in high uptake in the tumors, making them easier to identify. However, a common issue is the urinary excretion effect on PSMA scans, which results in high uptake in the bladder, and since this is often close to the prostate lesions, is therefore easily confused. In order to standardize diagnostics using this imaging technique, we believe an important first step is the accurate and automated segmentation of the bladder from the PET scans, specifically in a way that makes it easier to segment prostate tumors from these same scans. And so here we present our fully automated approach for bladder segmentation from this type of scan. Once again, our aim is to segment bladder regions from PSMA PET CT scans automatically, with the goal of using this information to inform subsequent prostate lesion detection from these same scans.
Our dataset consists of 64 PSMA PET CT scans and were segmented by a physician with the help of medical imaging software using gradient-based edge detection and thresholding techniques. Bladder, turp urethra, and prostate lesions were segmented on the PET, while the left and right vesicles and the prostate were segmented on the CT. While analyzing our dataset, we noted there were 4 cases of significant overlap between bladder and tumor in the ground truth masks. These misclassifications are likely due to their spatial proximity and high uptake values. Simply masking bladder labels from the scan when they contain ground truth tumor voxels would negatively impact tumor segmentation performance. This demonstrates the inherent challenge in classifying bladder versus tumor. Hence, traditional approaches such as region growing or edge detection may not be well suited for this problem. Our first step for data preprocessing is we discard 2/3 of the slices in the scan. Additionally, the regions of interest we are concerned with are always located near the center of the transverse frames, so we apply a center crop. To address the overlap issue discussed in the previous slide, we treat ground truth overlap as purely tumor pixels in our labels. For our deep learning model, we used an off-the-shelf implementation of the 3D UNet, running at a slightly reduced size. We used fewer feature maps to fit more samples in a batch, as well as to allow for higher resolution inputs. Our model has a total of roughly 4 million parameters, and training time for 1,000 iterations with a batch size of 2 takes roughly 2 hours. With regards to the training procedure, we relied most heavily on an objective function composed of dice and binary cross-entropy losses, and investigated the effects of various changes to the segmentation task on overall performance. We attempted to minimize bladder tumor overlap in the predictions by experimenting with the addition of an overlap loss term. This was calculated as the proportion of ground truth tumor pixels that are predicted as bladder pixels. We also evaluated the impact on bladder segmentation performance when the model is trained to predict tumor as well. Finally, we compared the effects of various data augmentations on our baseline performance. From these results, we can start to see the impact of the overlap loss and the inclusion of the tumor class. Both factors trade off with a dice score, causing a decrease in bladder segmentation performance. However, we can see that both changes also result in a decrease in the average proportion of the ground truth tumor that is mislabeled as bladder. Using the overlap loss, we can outperform the rate of overlap produced by medical imaging software. However, this comes at the cost of the other metrics. Here we see a slice from one of the 4 challenging patients with significant overlap in the ground truth. This is a good example where we were able to improve on our baseline's tumor overlap performance. This patient has an overlap of 22% in the ground truth data, which is decreased and removed across our different models. This is the most apparent in the tumor plus overlap loss model. We applied various data augmentations to 2 of our models to investigate their effect on model performance. We can see including data augmentations doesn't help our baseline model. However, with our tumor and overlap model, data augmentations mitigated the effect of these additions which slightly improved the DICE score.
So from these results, we can see that minimizing bladder tumor overlap often comes at the cost of bladder segmentation performance. One possible solution would be the inclusion of loss terms that consider spatial or structural information, or additionally, a term that considers the pixel values of the scan at the segmented pixels. Including the tumor class in the prediction task also had a similar effect. However, doing this allows for future thresholding between the two classes, which can give the user more explicit control over this bladder tumor trade-off. With regards to our initial goal, it seems that masking out segmented bladder regions from PET scans without careful consideration of tumor overlap may result in unintentional masking of ground truth tumor pixels. For the purposes of automating this task, it may be necessary to have some allowable margin of bladder tumor overlap. In conclusion, accurate differentiation of bladder from prostate tumors on PSMA PET scans is highly dependent on the location of these tumors and their proximity to the bladder. The framework we proposed here, which explicitly enforces separation between the two classes, was able to decrease the rate of overlap and outperform conventional segmentation methods. This approach holds promise for improving radiomics analysis workflows, affecting clinical staging and prognosis predictions. We believe that this is the first step in standardizing segmentation and reporting of prostate lesions from PSMA PET CT scans. We'd like to thank all of our co-authors and collaborators, as well as everybody at the Curate Lab and the BC Cancer Research Center. And finally, thank you for listening.